Good afternoon, everybody. Sorry about that. I had a few little technical difficulty there, but we're going to go ahead and get started now. Can everybody hear me okay?
Yep, we can hear you, Deb.
Okay, thanks.
We can hear you.
All right, thank you. So it is once again time for our stroke quality exchange. As you recall, this is a quarterly call that we, quality and systems improvement team have put together to share information with one another, to get new information out to one another, and all of that kind of stuff. So we really want you to be a participant. If you have questions, *6 to mute and *6 to unmute. So it's the same either way. Feel free to *6 and ask any questions anytime that you want. And as an extra incentive for that, we are also going to give a tote bag to anybody who speaks up and participates or asks questions in the chat box. So I'd like to start, first of all, by thanking those of you who were able to attend the International Stroke Conference and the reception. It was really it was a great reception and a great conference. For those of you who were not able to attend, if you have any questions about anything, then please let me know, and we did miss you. So first of all, I'm going to go over the agenda. We are going to provide some information about a national resource that's available to you called the Stroke Warm Line. I'm going to give some information about the Stroke Awards for 2017 for Get With the Guidelines. Go through the 2018 Early Management Acute Ischemic Stroke Guidelines, just a few highlights. This was just released and presented at the International Stroke Conference last week, so these are very, very new. Also provide some stroke resources and educational opportunities, and then a little bit of information on atrial fib. So I'd like to start by turning over this presentation to Lisa Hatfield, and she's going to give us some information about the National Stroke Resources, the Stroke Warm Line. *6 to unmute, please, Lisa. Are you there? Okay. Well, I'll go ahead and give you some information. The Warm Line is a new resource that's available. It's available to all stroke caregivers and stroke patients, or survivors and families. And what it does is provide support with helpful information.
Oh, okay, I'm back. Deb, can you hear me?
Yes, go ahead, Lisa.
Okay, here I am. I'm so sorry. Technical issues over here, too. You want me to start over?
Yeah, go ahead, please.
Okay. I've been here at the National Engagement Center for about 5 years. I'm the medical advisor. I'm an RN. And the Stroke Warm Line is a resource that has been here long before I came. Debbie McGill actually started it, and I think you're all very familiar with Debbie McGill, the editor of the Stroke Connection magazine. And we have 7 specialists on our team, and they work with me to provide extra resources to our stroke survivors and their families and their caregivers. So what I was hoping was, one of my former jobs, I was a discharge planner and worked with the Get With the Guideline team at the hospital and the stroke coordinator. So I'm very aware, we get calls from stroke coordinators sitting with the patient next to them, getting ready to go home. And a lot of times it goes to our regular specialists instead of one of our Stroke Warm Line specialists. And I would really like to be able to offer to those stroke coordinators the resources that we can provide from the Stroke Warm Line. We do follow up with our patients and families after they go home. We set up actually calendar invites with a lot of them and follow them, some of them for a year or better, just to make sure that that transition is a very smooth one for them. So there's a lot of things that we can provide them, and I would just like them to be aware that they are more than welcome to contact me personally by email or phone, the stroke coordinator. I don't want to be giving out my numbers to the families, obviously, but to start that process, because we could set up one-on-one appointments with the coordinator at the time of discharge. We have a lot of resources like discharge checklists that we can fax over to the hospital at the time of discharge, or I could actually, send out ahead of time to the coordinators to have in bulk so that they could have to go over with their patients and make it a lot easier at the time of discharge for the patients and families. There's just a lot of resources. The specialists are people, the one that's on the picture here, Janet, her mom, her sister, and her husband have all had strokes. So she's been a caregiver for several years, and she really understands what they're going through. And it's really a nice kind of a relationship that they develop with these patients and families and caregivers. So I kind of connect them with whoever, I listen to the calls that come in, and I kind of connect them with who I feel like is the best resource for the person calling. I just felt like it was something that we haven't really touched on enough with the stroke coordinators to use that resource that we have for them. And I thought this was a good place to kind of introduce that.
Anybody have any questions for Lisa? Star six, excuse me.
Hey,
star
Lisa.
Six.
Yes.
Hey, I have a quick question. Is the stroke warm line, is it a call center, or is it like a recording that they reach where they leave a message and then you pair them up with someone and get back to them?
Actually, it's a call center, and most of the time when people call in, they'll get one of our regular specialists. So the regular specialist will make a case, what they call a medical advisor case, and then I actually listen to the call that has come in, and I set them up with one of our stroke warm line specialists who calls them back. But they are given all the information that I hear from that call before they call them back, so they don't have to repeat their story. But what I'm thinking for the stroke coordinators is at the time of discharge, because I remember from working in the hospital, it would have been so nice to have somebody to call to set that person up with going forward, because even if they go home with home health or they go to a rehab, there's kind of, I've done all those jobs. I kind of know there's a little hole they go into that not everything's always transitioned perfectly between places. And this is that person that kind of a week later can call them and say, did everything get taken care of? Did the equipment get delivered home? Did you get your home health person coming out? Is everything okay? And then maybe 2 weeks later check on them, and a month later check on them to see. It's just kind of a connection that they have the same person to talk to.
Perfect.
So they have the same person that's,
Do you guys have like little handouts that we can give to patients for this?
Yes, we have lots of resources that we send to our patients and families. We can do it either by email or mail. There's a lot of resources. We have the discharge checklist. We have a finance guide. We have home daily care guides. We have all kinds of information packets. So it's kind of specific to whatever the patient or family needs.
Okay, thank you, Lisa. Appreciate that information. So next on the agenda is the Get With the Guidelines Stroke Awards for 2017. Just to give you some deadline dates, February 28th, we ask that you have all of your data from 2017 entered into Get With the Guidelines so that we can evaluate the awards. Between March 1st and March 31st, the directors will all run the reports and evaluate final data. That will give them some time to look over the awards and verify everything. April 1st, and then if you have anything too that they can contact you to see, make sure that there wasn't an extraction error or something like that so that you can fix it. Once that information is done, April 1st, all data will be pulled for the award. So after the 31st of March, then please do not enter any more information for 2017 because our awards will be based on that other information. In May, the awards are announced and sent out to all of our hospitals. In June, abstracts, just so you know, ISC abstracts, the opening for submission will be from May 23rd to August 14th. So we really encourage any of you, there's a lot of information and get with the guidelines, lots of process improvement things that you've done. So please, look at the information, consider submitting an abstract. Practical application of information is really good and really helpful for stroke coordinators. And then in July, the U.S. News and World Report advertisement will be published, and that lists all of the gold and silver hospitals, the plus hospitals, and the target stroke. And then, if you haven't heard, February 2019, ISC will be held in Hawaii. So now we're going to get into a little bit of the 2018 guidelines for early management of patients with acute ischemic stroke. Many of you were at the ISC possibly and were there to hear and see this presentation, but the actual guidelines here was released on January 24th, and it was published in Stroke magazine on that very same day. Just so you know, there's like 344 pages in this guideline, so there's a lot of really good information. And what happened was they took all of the information from any updates that were done recently, along with the new and revised things, and put that all into the one guideline paper. So it will be very beneficial for you to take a look at that, and you can read it in your spare time. And these guidelines supersede anything from 2013, the guidelines, and any subsequent updates. It provides the latest comprehensive recommendations, and it's based on the best evidence that's currently available. Acute ischemic stroke guidelines are new and revised recommendations, include pre-hospital care, urgent and emergency evaluation and treatment. That includes IV TPA and mechanical thrombectomy. In-hospital management and secondary prevention measures are emphasized, and prevention measures should be implemented within 2 weeks of hospitalization or within 2 weeks of a stroke. And then it also highlights the need for public education, and especially tailored to race, age, and gender. There's different causes of stroke for these different races and ages and genders, so we really want to get the education out on what anybody should look for. The key recommendations in 2018 guidelines highlight the pre-hospital stroke management and systems of care, emergency evaluation, which includes the telestroke and teleradiology. It talks a little bit about brain imaging, antiplatelet and anticoagulant therapy, blood pressure management, and additional patient care considerations. So again, these are just an overview highlights. There is a highlight paper that is on the AHA website that all of this information was taken from. So one thing I want you to know as well is we didn't know either what the guidelines were going to be, the new guidelines, so these are all new to us. So we are learning, and we will be applying these together as we continue to move forward. So expanding eligibility criteria for IV TPA and mechanical thrombectomy. In addition to the recommendations regarding mechanical thrombectomy, then the new guidelines broaden the eligibility criteria for IV TPA. So any patient who has a symptom onset of 4.5 hours or less from last known well needs to be evaluated for TPA. Everyone who's eligible for it should get it, and it should not be delayed to determine if they're eligible for another treatment, such as mechanical thrombectomy. Patients with severe stroke who meet criteria for TPA should get this treatment, and the physicians just, we don't want to wait to send them for mechanical thrombectomy. So oftentimes what happens is the TPA, the eligibility is considered. If the patient is a candidate, the TPA is given. While the patient is obtaining more imaging or whatever, then they are, regardless, then getting the ambulance there or the helicopter or whatever for a very fast transport for further information. The smaller hospitals often start the TPA and then put them in the helicopter and fly them either to a thrombectomy capable center, which is a new designation that the Joint Commission has put together. So there's now a thrombectomy capable, or to a comprehensive stroke center with the TPA running. When you talk, so also, you know, we're still considering the faster door to needle time, careful evaluation of these patients, including those with mild stroke. You know, oftentimes we may say that this is a mild stroke and they really do not need TPA, but it's really not based on the number anymore as far as the NIH stroke scale. The consideration more is based on, is this going to be a disability for this particular patient? So mild stroke is not really a good reason to not give TPA. Also, there were a couple studies that were presented. One of them was a diffuse 3 study that was presented at this particular meeting in ISC, and it was published simultaneously as in the New England Journal of Medicine, just hours before the guidelines were released. The great part of it is the team, the scientific team that was reviewing the guidelines, revising and updating, did have access to this information. So this information is included in the new guidelines. So it doesn't get any faster than that as far as getting guidelines approved and then, you know, getting them moving forward. So the update to the guidelines recommends treatment in select patients now from 6 to 24 hours. So what's different from the previous recommendation is that the patients who are ineligible for TPA may now be selected for mechanical thrombectomy if they're within 6 hours. In light of the new studies, the diffuse 3, and then there's a second study called the DAWN that's been published. That was published January 4th in the New England Journal of Medicine. And the new guidelines recommend thrombectomy in eligible patients from 6 to 16 hours after a stroke. And that is now a level 1 recommendation. And then on the basis of the DAWN trial, the results is reasonable in patients 16 to 24 hours after a stroke. And that's level 2A recommendation. So for sure, up to 16 hours and 24 hours is also a recommendation. If you have any questions along the way here, feel free to star 6 and stop me, and we can discuss.
Hello, Lisa?
Yes.
Hi, I'm sorry, not Lisa. It's Deb,
yes.
Right? I'm sorry. Could you just repeat what you just shared with me, the 6 to 24 hours, which study that came from, and then the 6 to 16 hours? Okay.
So on the basis of the diffuse 3 study, then it was the 6 to 16 hours. That was what that particular study looked at. And so that's a level 1A recommendation. The DAWN study agreed with that as well, but also increased that timeline from the patients from 16 to 24 hours after the stroke. So really the recommendation now is patients from 6 to 24 hours. Did that answer your question?
Yes, it does. Thank you.
Okay.
Hey, and this is, sorry, I was saying, yeah, who is this that's chatting with us?
Really, who is this and what hospital? We want to make sure you get your prize.
I'm sorry. I'm doing the mute on and off. This is Dava Williams from Memorial Hermann Southeast Hospital here in Houston, Texas.
Okay. Thank you so much.
Thank you.
Hey, Dava, this is Allison as well, and I'll just add a little piece to what Deb was saying as well, that in the guidelines, you know, it would be definitely important to go back and read the specifics on the mechanical thrombectomy recommendations. But what I would also add, and they made this a very clear point at ISC, was that the recommendations for those are different because of the amount of evidence we have and the amount of data that is available at this time, and that there's only one study really looking out to 24 hours right now, the DAWN trial. And so they can't give a level 1 recommendation based off of one study. But I think that, you know, right now they're looking for more more data, more evidence to show that that's really beneficial. And they also made the point that in any patients going beyond the 6-hour mark, that you want to make sure that your practitioners are utilizing the same criteria that was used for the Diffuse 3 and the DAWN trials. So in those two trials, it was very specific what the inclusion criteria was for those patients, and that you were only looking at patients who are good candidates, and that the procedure would be a benefit to them. So I just kind of wanted to make sure that was clear.
Okay, thank you so much, Allison.
You're welcome.
Hi, this is Alyssa at St. Anthony North Health Campus in Westminster, Colorado. I just had a question. You mentioned that you can access the 2018 guidelines somewhere. Did you say Stroke Magazine?
Yes, it's in Stroke Magazine, but I also put a link to it in the presentation, and you guys will be receiving a copy of this presentation, so you'll have that link to get to it.
Okay, great. Thank you so much.
You're welcome. Okay, so next, pre-hospital management and systems of care. So the recommendation is to develop a regional system of care with facilities that can provide the initial emergency care, including IV TPA. So before, we talked a lot about bypassing places so that we could get them to the endovascular as soon as possible. The new recommendation is sending the patient to the closest hospital where the staff can determine if the patient is eligible, if they're having a stroke, and whether or not they're a candidate for TPA. And if so, they should administer it. So again, time is brain. It's getting that TPA in as fast as possible, and then transporting for more comprehensive care. We need to facilitate the rapid transport to advanced centers whenever that's appropriate. So having transfer guidelines and having that information readily available for the staff so that they can quickly arrange the transportation to the higher level, whether it be thrombectomy capable or comprehensive. Also participate in a state data repository to improve adherence to treatment guidelines. We continuously use these things for continuous quality improvement, and it improves the patient outcome. And then the guideline recommends that these systems of care establish door-to-needle times within 60 minutes in 50% or more of the stroke patients who are treated with IV TPA, with the secondary door-to-needle time of 45 minutes considered. So as far as the IV door-to-needle times, there's been really no changes in that, and we really actually would like to get 60 minutes up to 75% or higher, and 45 minutes, 50% at 45 minutes is still the goal. Telestroke and teleradiology. So if there's no neurologist on call, the updated guidelines recommend using telestroke evaluations to determine whether the patients are eligible for IV TPA. So this could be those smaller centers who don't really have access to a neurologist, but may have access to telestroke, neurology through telestroke. And these are proven to be very beneficial. The stroke specialist uses the video conferences and can provide the Altiplace treatment guidance that's as effective as giving it as treatment given at stroke centers. So there again, may consider telestroke in order to help make that decision whether or not to give TPA. And those could be the acute stroke-ready hospitals or primary, whatever level of hospital. Telestroke may also be reasonable for triaging patients with acute ischemic stroke who may be eligible for transfer to receive mechanical thrombectomy. So if they may or may not be eligible for TPA, but may still be eligible for the mechanical thrombectomy. Brain imaging. The updated guidelines now recommend brain imaging, typically the non-con CT scan within 20 minutes after a patient with suspected stroke arrives at the hospital. The hospital's goal should be to achieve this in at least 50% of the patients who may be eligible for IV Altiplace or mechanical thrombectomy. So again, tighten up those times, looking at ways to save time and increase or decrease door to needle. So a little more on Alteplase. The studies and experience have shown use IV Alteplase for treating acute ischemic stroke. Therefore, all patients who are eligible should receive it, even if the patient's being considered for mechanical thrombectomy. So really, that's kind of the same as what the other recommendation was, and that is give TPA if they're eligible and do the mechanical thrombectomy as well. Exclusion and inclusion criteria for Alteplase has evolved over the years, so it's important that you do take a look, like Allison talked about, and review those updated criteria in Table 6 of the 2018 Acute Ischemic Stroke Guidelines. The goal for IV TPA is unchanged, and except for treating possible up to the 4.5-hour window. And then treatment may also benefit those with mild symptoms and adults with acute ischemic stroke who have sickle cell disease. That's what we had previously talked about. Mechanical thrombectomy, the updated guidelines recommend that acute ischemic stroke should receive thrombectomy if they have a pre-modified Rankin scale of 0 to 1, if they have an occlusion in the internal carotid or middle cerebral artery, if they're 18 years of age or older, if their anti-stroke scale is 6 or greater, they can receive treatment which is actually the groin puncture time within 6 hours of symptom onset. In addition now, with the new studies, mechanical thrombectomy is recommended for select patients who are within 6 to 24 hours of onset, and that they have a proven large vessel occlusion by imaging in the anterior circulation, and then that they also meet the DAWN and the diffuse studies, the eligibility criteria, just as Allison had mentioned a little while ago. Revascularization for carotids, this is another new recommendation. When revascularization is indicated for secondary prevention with minor disabling stroke, the modified Rankin of 0 to 2, it's reasonable that the authors to perform the procedure between 48 hours and 7 days of the original event, the stroke event, rather than delaying if there's no contraindication for early revascularization. The previous guidelines really didn't have a time frame on it, so the difference with this particular measure is that they have given us a time frame of 48 hours and 7 days of the initial stroke. Another thing that was highlighted is antiplatelet and anticoagulant therapy. So aspirin is still recommended within 24 to 48 hours after symptom onset if they do not receive TPA. It's reasonable that the patients with atrial fib start the anticoagulant within 4 to 14 days. Immobilized patients, they also recommend the IPCs to prevent the DVT, not the stockings, but the actual intermittent compression hose. And it's unclear if the prophylactic dose of sub-Q heparin, the unfractured heparin or low molecular weight heparin, is beneficial for the patient. So for acute ischemic strokes who are treated with IV Alteplase, then aspirin is generally withheld for 24 hours. That's not new. We're treated with IV Alteplase and have commitment conditions, then earlier aspirin treatment should be considered. It's known to provide substantial benefits in the absence of IV Alteplase, or withholding such treatment is known to cause substantial risk. So giving that aspirin by the end of day 2 without TPA remains very important. If the patients have a mild stroke and symptoms were not treated with IV Alteplase, then the dual antiplatelet therapy with aspirin and Plavix started within 24 hours and continued for 21 days may prevent a secondary stroke. So that also is a new revised guideline. So as far as the prophylactic for VTE, the heparin, the anticoagulation. It's not really known whether or not it's effective. Through the research that was done and the review of all the research, there is an overall benefit. The overall benefit of blood thinners is not clear, but the overall benefit of those compression cuffs is very clear. Blood pressure management. So the updated guidelines to manage blood pressure for acute ischemic stroke. So primarily, we've realized that it's okay for blood pressure to be high immediately after the stroke. If the patient's pressure is at least 220 over 120, he or she did not receive TPA or endovascular, then there's no reason to lower that blood pressure. There's no benefit in bringing it down. Before, when the patient's blood pressure was like over 200 over 100 or higher, we oftentimes thought that that was kind of an emergency situation and we needed to get the blood pressure down. But now we know that from the studies that this doesn't help and it doesn't hurt. But it just doesn't do anything. So another recommendation, So blood pressure. Early hypertension treatment to lower blood pressure in those who do not receive any additional treatment by 15% is probably safe. If the blood pressure is less than 2, if patients did receive IV TPA and have no comorbid conditions, then leaving the blood pressure at 220 over 120, there's no complications related to that. And there's no benefit to lower it. If blood pressure is 220 over 120 or higher, the benefit of lowering the blood pressure is unknown, but lowering by 15% in the first 48 to 72 hours after an acute ischemic stroke is reasonable. Those that receive IV Antiplatelet, then blood pressure should be maintained below 180 over 105 during the first 24 hours after the administration. And the pre-TPA blood pressure remains the same as well, at 185 over 110. After undergoing mechanical thrombectomy, it's reasonable to maintain blood pressure below 180 over 105 during the 24 hours after the procedure.
I have a question about the blood pressure.
Yes.
So we're saying it's okay to leave the blood pressure higher than 220 in certain situations, but is there a max? Because these people might blow a gasket.
Right. So what they're showing is that it's not really effective to lower the blood pressure, and especially if it's more than 15%. So the research is saying that they did not give a high number for treatment. So there's a lot of considerations by the physician as far as, what are the other issues that the patient is facing. So that'll be a physician decision.
Okay.
And who is this again? Sorry. Okay. So additional patient care considerations. In light of cost implications, an important new recommendation is ordering only the tests that are beneficial. So evidence does not support routine use of these diagnostic tests. So previously, we've had a battery of tests, the echo, the MRI, all of the blood work, sleep apnea. It's not necessary for every patient to have every study. Some doctors think that if they get more information and they gather through tests, then the better. But the idea of having a routine bunch of tests that you do on everybody is not very cost effective. No test should be routinely performed in everybody with a stroke. You really need to pick and choose which tests you do in which person to answer a very specific question. So you're looking for the cause of that stroke. The question is, does everyone with an ischemic stroke need an MRI? That was one thing. We've always just gotten the MRI the day after, but is that really necessary? They're actually saying that probably is not a necessary test. The intracranial CTA and the MRA, they are not necessarily needed on every patient. Prolonged cardiac monitoring, that same question is the same question is whether or not, if you monitor blood pressure or cardiac monitor, I mean, for AFib, 24 to 48 hours after that, it doesn't really show that there's a big benefit to that. The echocardiogram, the same question could be posed for those routinely undergoing echoes and bubble studies, even in the absence of heart disease. So if they don't have heart disease, there's no reason to think it could be a TFO, or then do you really need that echo? Blood cholesterol is not necessarily recommended as being addressed or reviewed by every stroke patient if the patient's not on a statin. If they're on a statin, then looking at the blood cholesterol is important. Obstructive sleep apnea is another potential cause of stroke. There again, not necessary to do a test on everybody. And then the last three things are the hypercoagulation studies, and they definitely do not need to be done on anybody unless there's a reason to believe that this patient is affected by that.
Hey, Deb, this is Allison. I just wanted to jump in real quick, and I wanted to reiterate to everybody that we're definitely not saying that you're never going to do these studies and that you're going to just eliminate them from your battery of your stroke workup in general. But what we're saying is to please consult with your physicians and to let them know that it's probably not the best idea to just do a blanket stroke workup on every single patient, and to really take the time to consider. Obviously we know there's cryptogenic strokes, and we have a hard time figuring out what the cause was. And then in those instances, it might be, worthwhile to go do some more studies to try to find out what caused that stroke. But if it's a pretty clear-cut indication of what caused the stroke in the first place, there really isn't a lot of reason to waste the money and the resources on doing a bunch of other studies just because it's part of your, quote, stroke workup. So you can definitely go into the new guideline and read more about this and kind of what they're recommending and where they're getting that information from. And I definitely recommend you do that. So please come back to us if you have questions about this. I know it's definitely a change from the way we've thought in the past several years about how to treat stroke patients in the hospital. So we welcome your questions on that. And Deb, I'll turn it back over to you. Sorry.
Okay, no problem. Thanks, Allison. Yeah.
This is Ashley Gross from St. David's Georgetown Hospital. You said to reference the criteria and the guidelines, these evidence for the diagnostic testing will be in that link that you're going to send to us. Will that also be there?
Yes, it's in the 344-page document. We're going to find all that information.
Awesome. Thank you so much.
It's a little easy reading. Yes, there you go.
Okay, I have
thing I'd like to. Oh, go ahead.
Oh, I'm sorry. This is Tina from Conroe Regional Medical Center. I have a question, possibly for Allison. As far as the blood cholesterol, is that going to be a measure that will still abstract and to get with the guidelines? As far as an LDL?
Yeah, that's a great question. So kind of back to the point we made a little bit earlier, like we said earlier, this is all very, very brand new for us as well. We just are, obviously getting these guidelines within the last week. And the plan is that once the guidelines committee has made their recommendations and released, published the guideline, it then actually needs to go to our national measures committee, and they will make the determination as to whether or not these measures will remain and get with the guidelines, or if they will be changed or eliminated completely. So kind of stay tuned, because that process is a little lengthy and it could take a little time. So everything now and get with the guidelines, the recommendation would be to continue on as you've been doing, and certainly start looking at these new guidelines and working to find ways to incorporate them into your practice. But the get with the guidelines measures are not changing just yet.
Okay,
so
great.
We'll definitely let you know when that's going to happen.
Okay, all right.
I think it's important to know. It's depending on who your accrediting body is, DNV or JCO or whatnot, we want to make sure that we're following their recommendations in addition to American Heart.
Yes.
Absolutely. Sorry, who was that?
Oh, I actually
who was that?
did contact the DNV and ask them both actually the Joint Commission and DNV, and to ask to see when the expectation is that these new guidelines are implemented. and it's really too soon for them as well. There's a lot of things that need to be looked at.
Right.
One thing in particular that people had talked about was dysphagia screen. The recommendation actually says that there's no benefit to the dysphagia screen, that it really doesn't necessarily prevent pneumonia and some of those complications. However, it is still recommended. So when you read through the guidelines, it says that there's no research saying that it's of benefit, but we believe that it still is. So that probably will not change. Other questions?
Sorry,
right.
I didn't catch the name of the last person that jumped in. What was your name?
It's Jolivon Romero at Lovelace Medical Center.
Thank you, ma'am.
Okay, so utilizing resources appropriately. Basically, that is what we are saying, or what the guidelines are saying. If the AFib cardiac monitoring for at least the first 24 hours after acute ischemic stroke, but prolonged monitoring to detect AFib is not very useful. If the patient's taking a statin, then it's reasonable to resume their medications while they're in the hospital. Also says that if the patient is less than 75 years old with acute cardiovascular disease, that it is reasonable to continue or start the statin. And if the patient is greater than 75 with the cardiovascular disease, then it's important to evaluate to see if there is a risk reduction for additional strokes. Insufficient data, whether screening, this is for dysphagia, I think, sorry. Insufficient data where screening protocol decreases death or dependency. So there's not good data that says that this is going to decrease mortality in our stroke patients. However, for acute ischemic stroke patients who are hospitalized, screening for dysphagia before the patient begins eating, drinking, or receiving oral meds to identify patients at increased risk is still reasonable. And if the patient's ability to eat is limited, then the healthcare provider should start tube feedings within 7 days. So those are all part of the recommendations as well. Prevention is part of the acute treatment for patients and should begin day one. So immediately when the patient comes in, we should be looking at prevention, how we can prevent additional stroke. So now that is kind of the very high highlights of the new guidelines. Does anybody have any questions or comments that they would like to share regarding the guidelines other than what's already been talked about? *6 to unmute.
Hey, Deb, it's Allison. I just wanted to jump in really quick and share with everyone. They've changed the recommendation system just a slight little bit compared to what it used to be. We've always had the 1A, 1B, 2A, 2B, those level recommendations. They've added a couple of categories now that look at limited data sets and expert opinions. And I just wanted to kind of share with you all that take a quick peek in the very beginning of the new guideline, and it will kind of give you an overview of how the new rating system works. And it's kind of helpful as you're reading through the guidelines to see what the different levels of recommendation are and why they're given that level. In addition, I just wanted to also mention too that the guidelines committee remains solely based on the science. They really do a very good job of avoiding any conflict of interest. So if there are committee members that are working with pharma or any other industry, they are eliminated from any kind of vote or determination on whether or not something becomes a guideline, just so that we can avoid any kind of conflict of interest. So rest assured that the guidelines you're receiving are as much based on the science as they possibly can be. And that's that. I just wanted to leave that there.
Okay, thank you, Allison. Some of the resources we would like to share with you, if you haven't already on your phone, you can download guidelines or AHA Guidelines on the Go. It's a mobile app. It's for Androids and for iPhones, and it's really, it's pretty amazing. It puts all of the guidelines at your fingertips. When it first comes up, it gives all of the guidelines. You know, there's icons. And then if you click on it, it will take you to the actual articles, the research information behind it, and then also anything new that's been added for a recent guideline. It'll be kind of a pinkish color when you actually get into that guideline. It just indicates that there is something new in that guideline. So I would encourage you all to go to get Guidelines on the Go. It's really very cool. I didn't even really know about it until recently. So feel free to, it's a free app, go and download that. Science News, so the 2018 Guidelines for Early Management of Patients with Acute Ischemic Stroke. So there's a lot of, if you go to that Science News website, then there is a lot of support materials that also will provide some information. So like the accuracy of predicting instruments, they did talk about the different severity scales, so you can learn more information about that. The effect of the dysphagia screen. The 2018 Acute Ischemic Stroke Guidelines, the highlights for that, that's the highlight sheet that I was telling you about. There's the top 10 things to know that you can pull up. It's just a little PDF form that gives some more information. The clinical slide, this one right here, clinical slide set for 2018 guidelines is really very good. It's 143 slides, but it goes through a little bit more information, not as in-depth, of course, as a 344-page document, but there is more information in that slide set, and it may be very useful for you to review those. And then just more stroke patients are going to be eligible for the treatment. There's information about that as well. So again, I didn't add the 2018 guideline, the link to this, but I will before it's sent to you. Another thing that I would like to let you know about for educational purposes is we do have the American Heart Association Stroke Webinar Series. This series is put on by the Southwest Affiliate Stroke Committee, which is comprised of physicians and nurses across all of the Southwest Affiliate, as well as some ancillary people. So the next one will be March 5th. And the Stroke Systems of Care in Oklahoma, that's what the next series will be. And you can click on the link here and go to that to register if you are interested in that. Cryptogenic Stroke Initiative. This is a big new initiative. You know, there's so many patients that we don't really know what the cause of the stroke was. So there is going to be a series of webinars to talk about cryptogenic stroke. And there's free CMEs with this as well. Actually, the first one is today at 2 o'clock, I think. Oh, hold on, it's on the next one. But you can register using the link here. There's case studies there. They're really good. There's a Code Stroke Team quick sheet that you can download and use. And then there's also a couple of videos that healthcare providers and patients have put together that are really very good, talking about cryptogenic stroke and the importance of trying to find it. So this here is the website in order to get to that so that you can check out those resources. So the AHA webinar is the evaluation of patients with cryptogenic stroke. It is today at 3 o'clock, I think it's Central Time. But there again, if you go to this learnheart.org website, then you can sign up for that. And it's free, and you also get CEUs for that. So they're looking at prevalence of AFib after the cryptogenic stroke, its role in a recurrent stroke, review current recommendations and controversies for PFO. So there's going to be some really good information about cryptogenic stroke. So we'd encourage you to go ahead and take a look at that. And now I am going to turn it over to Allison Capetillo. She is the stroke lead for the Southwest affiliate and the director, AHA QSI director in Houston. Allison?
Thanks, Deb. I am going to talk to you guys just a little bit about one of our other Get With the Guidelines modules that we offer. It's probably not one that's familiar to all of you. It's called Get With the Guidelines, AFib, and I know we've probably sent it out to you from time to time, but really we kind of want to share it today because we know that atrial fibrillation is one of the most expensive diagnoses that we have and causes a lot of readmissions and definitely causes strokes, so that's why it's important for us to think about it. But it's something that you may want to consider as your hospitals start looking at ways to prevent readmissions and start looking at some of their more costly diagnosis groups. So just some quick facts here for you to look at. So did you know that there are more than 2.7 million people suffering from AFib, and that number is expected to double by 2050? The costs surrounding AFib are estimated to be about $26 billion with a B, annually, and each hospitalized AFib patient costs in general about $8,750 extra for each hospitalization. Also, this is a group of patients that does cause penalty for hospitals if they are readmitted within 30 days of discharge. And this can be highly likely, especially given the number of comorbidities they generally have and the high risk they are for heart disease and stroke. Next slide, please. So just this is a little quick infographic to kind of show you the prevalence and what they're at risk for. AFib patients are usually hospitalized twice as often as non-AFib patients. They have a 5 times increased risk for stroke and a 3 times increased risk for heart failure. They are 3 times more likely to undergo multiple admissions. So obviously, just based off of those facts alone, you can really quickly see that this is a population you would definitely want to put some focus on, especially as your administrators are looking at ways to reduce costs and to reduce readmission rates. Patient care is not always consistent. We know that with these populations, they're seeing multiple providers in the hospitals, especially if they're seeing hospitalists in any number of locations. So it's very important to streamline the care they're getting and to make sure it's following the evidence-based guidelines. Right now, only 50 to 60% of eligible patients are getting anticoagulants. And we know, especially with stroke patients, that this is key to preventing a major stroke from occurring. If they are not on an anticoagulant, we don't know if there's a way to keep them from throwing a major clot. Gaps in care can result in serious complications. Obviously, they're high risk for stroke and heart failure. Next slide, please. So in the Get With the Guidelines PMT for AFib, it is set up just like you see it in stroke. It's the same format, same user capabilities and reports that you would see in your stroke. You're going to see similar ones in AFib. Obviously, there are less measures for AFib. Stroke is our most robust registry, but there are lots of really valuable data collection points in AFib. And I'd also like to add that there is capability to have an ablation registry tied in with your AFib module. So we do offer an ablation registry. As part of it, it is free. It's not any extra cost. So if you do the Get With the Guidelines AFib, you can also capture that data for your physician. So you have electrophysiologists in your hospital that are looking for ways to capture that data somewhere and they would like to keep a registry of sort. This would be a good option for you, and it's obviously a little more cost effective than what some of the other registries cost. As with all of our registries, we offer education, we do webinars, we'll do workshops with you, and there's also patient education information tied in with it. And like every other registry we offer, you also have the chance for public recognition if you meet 85% or higher compliance in the achievement measures. And again, that bronze, silver, and gold level of award. And I think, is that the last slide for that one, Deb? I think. Oh, yes, that was it. So that's it. If you have questions about Get With the Guidelines atrial fibrillation, I certainly recommend you seek out your local QI director in your market, or if you want to reach out to Deb, we can get you in touch with the right person as well. So we hope to hear from you guys soon on that. And Deb, I'll let you jump in and talk about Wear Red Day.
Okay. So our National Wear Red Day is scheduled for February 2nd of 2018. So if you would all wear red to show your support for cardio disease and stroke, we would really appreciate that. And finally, be determined to achieve your goals. If you have questions, you can contact me, and this is my phone number, or you can contact your director, Allison Capetillo, or your local QSI director for more information. So it looks like I'm a couple minutes over maybe, or almost over with the presentation. But if there's questions, we can take a few questions, and then if there's additional information you need, then please contact your director. So any questions at this point? *6 to unmute. Okay.
Hello, this is Tiffany.
Oh, go ahead.
Sorry, St. David's, North Austin in Austin, Texas. I just haven't seen a response in the chat box. I was wondering if Lisa has like a postcard size or a page, quote unquote, ad for the warm line, and then we can just automatically include that in all our resources we provide to our stroke patients. Or is that something available on the website?
Is Lisa still on?
I don't know if she's still on. If she's not, Tiffany, we'll get with Lisa and find out if they have some sort of.
We're still on.
Oh, she's here! Yay!
Yeah. We do not, but we could certainly, I'm sure, put one together. We could especially put it in digital format and then send an email, and people would be able to print them off.
That would be awesome. I appreciate it.
Mm-hmm.
Any other questions, or you can type a question in the chat box if you would like. Okay, well, this is the end of our time together. Thank you so much for taking the time to listen to and participate in the Quality Exchange, and the next one will be, it'll be quarterly, so we will be sending some more data information to you later, and information about when the next quality exchanges are. Heart failure was this morning, if you missed that, and then tomorrow is the CAD quality exchange and resuscitation. No, sorry, resuscitation tomorrow and RQI, and then on Thursday will be the CAD. So again, thank you, and we appreciate your time.